So Mark's going to introduce Dan Hanley, but who's our speaker today. I just want to give a little bit of historical perspective. It's terrible when you can start doing that because it means that you are well on the downhill slide, right? So, but Dan was the person that, along with Dr. Long, started the neurocritical care unit. And Hopkins is very into, as we are in neurosurgery, into being first, into being leaders, and to lead the field. And Dan Hanley and Dr. Long really did lead the field of the neurocritical care concept. And there were giants that trained at that time. I mean, there were people, that went on. Cecil Burrell went on to be the NCCU director at Duke. Mike Dieringer went on to be the NCCU director at WashU. Jeff Kirsch went on to be the NCCU director and head of anesthesia or neuroanesthesia at Portland. John Ulatowski, who was chairman of anesthesia here, was in the NCCU as a fellow, and then did neuroanesthesia in the NCCU. Mark Mirsky, who was here recently, maybe still on the faculty, I'm not sure, in anesthesia, but he left to start an NCCU program in Hawaii. These are all people that were actually fellows while I was a resident. The place was packed with talent, and much of that goes to Dan's credit. And, the NCCU at that time was 6 rooms. Okay. You know what the NCCU is today, 6 rooms. 2 of them, believe it or not, were double rooms. There are 8 patients that could be in the NCCU. 2 rooms had 2 patients in them. So it was a very small unit, not much bigger than this room here. And it was an amazing, experience as a resident to train there. And you really had a very close relationship with the faculty and the fellows, and really started the whole field of neurocritical care. And so it's really an honor for you to be able to hear Dan talk, because he really was a visionary along with Dr. Long. So Mark, you want to come up and introduce him?
Thanks, John. I think you've already heard an excellent introduction as to Dan's history. We're here to talk about the collaboration that's evolved and is very strong both in the past and then I think in the future that is required for often complex clinical research projects. We're really fortunate here to have a group that called BIOS, and you're going to hear more about that momentarily, which helps design and continue and operate clinical trials right here at Hopkins and throughout the country, and specializing in neuroscience. And not only do they do that and help us all build these studies, but they're also principal part of the what's called the TINS, the Trial Innovation Network. This is a network that is on the leading edge of trying to develop new methods of clinical trials to help them improve their function. And I think we stay, and I know our study also gained a lot from being part of that and getting consultations from that. So that was led by Dr. Dan Hanley, and you've heard his introduction. I'm just going to say he's iconic and has started the NCCU, and we're really pleased to have him here, and pleased to have him here as a collaborator in all these clinical research projects. Thanks.
I think I'll just sit down after all of that stuff. I like the word collaboration, and I think that's important to moving things forward. It's the 25th year of our academic CRO, the Brain Injury Outcomes Clinical Trials Coordinating Center. And we're celebrating it by doing grand rounds with the leaders in the various departments of Hopkins whose trials we've helped. And Mark, along with Mark Hamilton, a neurosurgeon from Calgary, and Mike Williams, who you forgot, who was also a fellow here.
Oh, I remember Mike.
Yeah. Have done this wonderful trial PENS, which Mark is going to talk to you about. And we're going to talk to you a little bit, Nicole McBee in particular. And if we have time, a short panel afterwards about how we help and collaborate with investigators like Mark. There we go. These are our disclosures, the objectives, so you can get your CME. This is a tree of all the trials that have come out of the NCCU. And this one here has ICP-related trials, which actually started with something that Don Long asked to do. He said, why don't you take these hydrocephalus patients and stick them in the NCCU and measure their ICP? And Mike Williams was the fellow who did that. And it's the first of multiple trials in this area. The best of the trials are the ones that Mark brought to us. We do three things, and Mark's going to tell you a little bit about that. We do trial planning. Once we have a plan down, we do grant or proposal organization, and then we do trial operations. And everything we do is predicated on trial operations. So you can think about going back up that staircase of three blue activities. We're going to have Nicole McBee, who was in charge of overseeing the operations of the PRINCE trial, talk about it after Mark tells us about the trial. And two of our trial scientists, Karen Lane and Lindsay Ezeguer, will be on a short panel afterwards. So Mark, tell us about PENS.
Well, I've spoken here, ran rounds at least once or twice about PENS, but I thought it would be an appropriate time for an update. PENS, and I guess appropriate time because in part we just published an article giving really the preliminary results, so the full results of all the patients, but only the 3-month follow-up. But this 3-month follow-up was an essential part of one of our goals, and that is establishing normal pressure hydrocephalus treatment with shunting in an unbiased controlled study. So this is very much a team effort. As you can see, there's many people that have been involved, many sites involved in this study. And so it was quite an organizational effort and a team, in a sense, again, a team of teams, if you will. Here you see a list of the participating sites. They include one in Sweden, 2 in Canada, and a total of 20 sites, 17, which ended up giving patients to the study. So just so everyone's on the same page, those of you who need a reminder of normal pressure hydrocephalus, it was first presented in 1965 by Solomon Hakim and co-authors in Boston. And it was a discovery of a syndrome in the elderly patients of principally gait disturbances and balance problems, but also problems with cognition and urinary incontinence, and involved, of course, ventriculomegaly, but a chronic ventriculomegaly and hydrocephalus without an elevation in pressure. So from this beginning, there was a great deal of enthusiasm about this new phenomenon, and the enthusiasm was based on the fact that it could be reversed with shunting to a really sometimes impressive amount. And in the 60s and 70s, there was a lot of shunting that was performed. Much of it successful, but there were some difficulties. I mean, shunting itself was in a bit of its infancy, and the selection processes weren't all clear, and there were both complications and failures. By the 1980s and early 90s, there was indeed some skepticism about is this worthwhile doing surgery in the elderly patients? They're at high risk for surgery of any kind, even smaller procedures. And do we really have good evidence that this works? Well, this sort of equipoise was again reinforced in a paper in 2013, and even as recently as 2017 and then 2024. In 2017, the Annals of Neurology asked the question, should we be doing shunting for hydrocephalus in the elderly? Where's the evidence? And this is something that we had long thought about, and I'll show you how we developed the idea and the study. And as late as 2024, a Cochrane review was done that concluded there's very little evidence that NPH helps in terms of a real controlled trial. And they called also for more research and more work. So How did this idea evolve? Well, it's been a long road, and I've discussed it before, so I'll just mention it briefly that it was way back almost 20 years ago, about 18 years ago. We were thinking about placebos in general, and specifically that neurosurgery can be a very strong placebo in terms of a functional outcome. And we had formed a very small group with Jan Malm in Sweden and Mike Williams, who was then here, still in Baltimore, and I was in Cleveland, where we met every Wednesday and talked about how we could create a trial, a well-controlled, placebo-controlled trial, which would test once and for all if IMPH was really, really useful. It's hard, as you guys can imagine, to create a placebo-blinded, placebo-controlled trial in a surgical procedure. You can't do fake operations. So we had to figure out a way. And the first way we thought about was ligating it in some people and then doing a procedure to unlig it later on. So everyone gets a shunt, but it's tied off at first. Well, that involves more surgery, some more risk, and so forth. So there's obviously some problems with that kind of approach. There's also problems with some people just saying, hey, we think it works. The fact is that people in the field, although they're the same people that see all the benefits of the people that are shunted, also have questions about the nature of the improvement, how much of it is functional, how much of it is true physiological, and also how to select the best patients. So that partnership continued for a period, and you see here we're up to 2010 and beyond. And we faced several roadblocks. First, we actually developed a clinical trial and brought it to NIH and the NINDS, and they basically said, I think it's established. I think you just got to figure out who to do it on. And we were a little bit surprised because we knew the people in the field weren't sure about that, and we knew that there was no evidence even back then. So we kept at it and tried different approaches. A valve came out, we'll talk about it a bit further, that actually has an off to it, a virtual off. And you all know this valve, the Certus valve. And this made it possible to have a different approach. It made the study of the valve function in shunting a non-invasive a way that we might be able to study in our patients. So we continue work on, but again, there were roadblocks. You see a lot of years in there. The valve that we had hoped for actually was discontinued for several years because of defects that it had to come back. That's why it's called the Certus Plus. And also the company that I was negotiating with for literally 2 years to get a little startup money and pilot money dissolved. Right at the last minute when we were signing the contract, Codman Johnson Johnson disappeared and was reborn as Codman Integra. All the contracts were lost and we had to start again. So obviously roadblocks can occur and you just have to keep going. But I think the biggest issue that we had was we didn't have the appropriate infrastructure. We didn't have a system of researchers and ways of collecting the data, everything, all the protocols written out, and the people and structure to do a large scale placebo-controlled trial. So in that period of time, we founded with 5 institutions, and this included Mike Williams and Mark Hamilton from Calgary, who is now the director of the AHCRN. This is the Adult Hydrocephalus Clinical Research Network. This gave us a coming together of people in hydrocephalus that could develop protocols, ways of evaluating for the results of shunting and evaluate these patients. So then here we had the registry and a vehicle that we could stand on to do even a pilot study and also, of course, apply for a bigger grant. So after long last, the pilot study was funded. It was funded by Integra in 2020, something like that, or maybe a little bit earlier. And at that same time, we were gaining contacts with people in NINDS and discussing our progress, but importantly, through the HCRN with the Utah digital the data control people. The statisticians were ones that were also involved in the hydrocephalus, the children's hydrocephalus clinical research network. And now we were enlisting them with the adult hydrocephalus clinical research network. And they were also on board to help us. So in other words, we're gaining people and also consulting the TINS group I mentioned and the CT, there's a lot of numbers here or letters, CTSA, which we'll talk about in a minute. we got to the point where we were able to do the pilot study, and luckily it came out with positive results. And during that time, we went through this pretty long procedure of building the study, and one of those things was involving the CTSA and the TINS program to try and find out what centers out there through the country would be best to involve with the study. So we spent the summer interviewing places throughout the country who had the facilities, who had the PI of interest, who had the equipoise to really do the study with us. So we gathered we talked to many more, but we gathered about 20 sites that we felt would be appropriate. So that was a project in itself. And through that, though, we have a network, the PENS network, which we hope not only can function for this study, but for studies in the future. So we then went ahead and applied for the U01 and received the grant. So now we have the PENS project, which started formally in 2022 and is extending now to 2027. So we're sort of in the middle of this. This first publication, again, represents the first 3 months of results. We're also going to be following patients into the next year. We'll have a paper in 2026. And into 2027, we expect about 5 to 7 papers to come out about not only the efficacy of shunting, but the prognostic factors, biomarkers, and also hopefully also about the physiology of hydrocephalus. The primary goal of this study, however, is to demonstrate the effectiveness of INPH shunting with a placebo-controlled clinical study. We also, of course, wanted to look at the biomarkers to decide what would tell us which patient to shunt. And so we have a full battery of the biomarkers as well. And as I said, hopefully serve as a platform for other studies. Here's an overview of the design of the study. It's a simple design. It's called a delayed protocol, the delayed treatment protocol. You use standard care, diagnosis and treatment in what's called an effectiveness trial. In other words, there were variations in how the sites evaluated their patients for improvement. We allowed those variations. We also said that they should shunt patients in the way that they usually shunt them, with some exceptions. Had to be on one side and so forth, and had to use a valve that could be shut off, so the Certis valve. And so in that way, we wanted to ask the question, is shunting as it's done right now around the country, is it effective, even given the variables? So these patients were selected after shunting at 3 months' time. They all had functional shunts, but during the initial 3 months, half of them were set at a level which was, quote, virtually off. The other half had normally active shunts. That is the experimental period that we're reporting on right now. But we have, of course, continued to follow these patients over the full months. So this is a blind randomization by the surgeon just before the surgery to open a placebo group. The delayed treatment paradigm allowed everyone to get the same shunt and everyone eventually to get some shunting at the 3 month period of time, and allowed analysis both of the short-term placebo effect, but also long-term durability of the response. There are secondary, tertiary, and other outcomes here. I'm not going to list them all, but they involve functional neuropsych tests. In many, but not all the patients, there was extensive neuropsych tests that being done, both baseline, 3 months, and will be done at 12 months of complete shunting. So we're going to have a lot more information on many of these variables in the future, and including CSF biomarkers as well. The primary intervention is important because it's not shunt surgery. We didn't do a trial of shunt surgery. What we did is have an intervention be just that setting. As I said, half of them open, half of them closed. And we use the Certis Plus valve, not because we think it's the best valve for NPH shunting. We believe that any differential pressure valve that can regulate appropriately can be used. We use this valve because it had that setting of off. So we don't want to imply that this is just for this valve that is the only one that could be used for NPH. But the use of this valve with that offsetting allowed a non-invasive blind adjustment. They don't know how we're adjusting it. Neither does the family or any of the caregivers or any of the assessors. And it allowed an acceptable and ethical design. The outcome is change in gait velocity, measured at 10-meter walk in milliseconds. This was highly standardized because it's the primary outcome, and it was trained. And we have videotapes of the walking measurements, and we followed them in the central lab, and we corrected there were some errors, and there always are in studies. We had to go out and correct if they weren't doing it properly and so forth. So this was a highly controlled variable through a central lab and through training and continuous observation of the data as it came in. The patient selection occurred over about a year and a half to 2 years, and it was only surprisingly for 100 patients. This was allowed us to get a greater than 90% power to detect a group difference of 0.2 meters per second. And that sounds like a small number, but we're going to talk a little bit more about what is clinically important. These participants were already evaluated as I said, in the standard fashion according to guidelines that are international about how they should present and how they should respond to a CSF drainage trial. Again, the exact criteria and the method they did the studies with the exception of the walking study was variable in the different sites. The surgical procedure just required them to have it on the right side, have the valve in back so it didn't interfere with our MRI quantitation. And aside from that, and the use of the Certus valve, they did the shunting procedure in their own fashion. Excluded were people who were walking too well that we thought that they may not show much more improvement specifically because our main variable was walking and walking deficit, or people that could not walk at all because that was going to be unmeasurable. So we have people, which are the majority, in the middle where they have deficiencies in walking and balance, but they still have the possibility of measurement and improvement. Also excluded were previous cranial surgeries, anticoagulation, comorbidities that would interfere with the ability to perform the assessments. I should stress that we did allow people who had the diagnosis of other dementias and other problems, because that's what happens in the real world. Some of these diagnoses are given to the patient and they may not even be totally confirmed, but we allowed for this as long as they showed improvement with the drain, and as long as we didn't feel any of the comorbidities would interfere with their ability to show a improvement. For example, if someone had a severe hemiparesis, they very likely would not be a good candidate to follow for the gait analysis. This is a flow diagram. I'm not sure how much you can read the details, but as you see, I think about 1,400 patients came through the study. They didn't come through the study. They were evaluated at various centers during the period of time. Of those, 485 were, shuntable, which means that they did respond to a CSF drainage trial as done routinely in these different sites. Out of those 485 shuntable patients, 301 were considered eligible by the criteria to be in the trial. So that's about 62%. We approached 237 of those 301 eligible patients. And this is the part that was of concern starting the project, but 53%, 53% were approached and consented. So there was a lot of concern that people would want, they wouldn't want to be part of any study. They just want their shunt and they want to get better. Don't blame them. But I think the study had enough positive features of observation and also the hope to help future people that the consent rate was higher than we had anticipated. So just to get to the results quickly, the final results, but only of the 3-month placebo trial was, I should mention, we powered 100, and I'm going to talk about 99 patients, half male, half female, and also half with open shunts in the beginning and half with the placebo group. And it's 99 because the data safety board, they stopped the study because they had done an interim analysis that showed that we were already significant. So we actually had one patient that was about to get a shunt to make 100. We had to stop it because they said, no more, you're done. So that was encouraging results, but that explains why we had the 99. The characteristics, as I said, pretty equal in male and female. The average age was 75. And 63%, so the majority of patients had a college degree. This is a bias that we're investigating. We know that we're seeing only a portion of the patients that could be evaluated for NPH, and they often tend to be European and educated. And we're currently looking at how those barriers might be stopping people from getting more evaluations. We do estimate that perhaps 1 out of 5, 20% or less of the people that should be evaluated for normal pressure hydrocephalus are actually evaluated and considered for the shunting. So we feel that getting the word out about the efficacy of this treatment is important, and we hope that that's how we can move the needle best. These groups, as mentioned, were similar in age, sex, educational attainment, and comorbidities. Here's the actual results. And this is, after all this is kind of in a nutshell what we found, but it was exciting to find that there was extremely significant difference when you look at the change in gait in the open group, the group that was shunted in that first 3 months, which is the top panel, compared to the group below, which is the placebo panel. The red line going down through marks the minimal clinically important or substantial clinical important change or difference. Is the MCID. And you can see that with the shunt open, many of them are above that line. And indeed, when you look at what the minimal clinical important difference is, we are at least 2 times larger in effect than what is considered clinically important difference and highly significant. So bottom line, this says that there is a difference, that shunting itself, even when evaluated totally blindly, makes a difference in these patients. Overall, when you look at the minimal effect, 80% of the patients in the open shunt group showed the improvement, and 24% did show improvement even in the placebo group. Quickly over the secondary, we see Tenetti, which takes into account balance as well as gait, showed a significant result. The others right now, MoCA did not. But we are looking forward to looking at the neuropsychiatric testing that is already being done, the extended testing, and also the results after 1 year, since things like neurocognitive changes can take longer than the first 3 months. There are other tertiary, many neuropsychological testing, as I mentioned, that are being performed. These aren't corrected for multiplicity, so I'm not going to give any p-values, except to say that almost all of them, except the depression rating, showed increases in their function, so they all went in the direction, in a more general way, of improvement. Here you see the modified Rankin score was increased, and the card sorting task is a test of executive function was also significantly increased. So this showed that throughout the study and the measurements, we're seeing trends towards improvement that we hope to see more of in the 12-month study. At the lower panel, we see the imaging also changed. We had to make sure that our shunts were off and the shunts were on. Well, it's true that the on shunts, those patients showed smaller ventricles statistically, and those in the placebo group did not. So we know that we were controlling the CSF the way that we expected to. This is a picture of the dichotomies, modified Rankin score. By dichotomize, I mean you're separating out, quote, the good ones, scores 1 through 2, from the ones that weren't doing so well. The top panel is the group that was in open shunting, and they did better, or they had a larger percentage of those doing well after the 3 months of shunting. And if you look at the lower panel, those are the placebo group, they did not do better after the 3 months. As a matter of fact, they did even perhaps a little bit worse. The open shunting incision went from 54% doing well to 78% in that 3 months. And the other group went from 45 down to 43, but essentially the same. So even the modified Rankin score, which is a pretty blunt instrument, did show some improvements. There were complications. Some that you might expect, of course, that the participants in the open group had less falls than the group where it was closed, suggesting that even after 3 months, you can spare some people they're falling approximately 1/2 if they are shunted. On the other hand, if you're shunted, you're more likely to have a headache, which also is pretty familiar. And we had to make some adjustments to reduce people's headaches during that first period. Finally, there were complications. There were 6 subdural hematomas. 3 of those were treated just with adjustments, and 3 in the study did have to have Burhole evacuation and/or embolization. And there was 1 death due to intracerebral hemorrhage and a pericatheter bleed that occurred. These complications are known and of concern, of course, in all surgery and this surgery, but we're certainly within the limits of other studies and what we'd expect to be in a range of safety, so that we could say that this procedure is still a relatively safe procedure. So in conclusion, we say that this shunt surgery is effective, that it improved gait, but also had trends improving many other factors, including Tenetti and the modified Rankin score. And the placebos did show no change. So these I mentioned the complications were comparable or better than in previous studies. So that summarized the results of the study. And I just end by saying that gait velocity is not just a number. It's an important factor because it's been shown in the literature that if the gait is decreased, that there's 5 times higher risk of falling. And the amount of improvement that we saw in these patients gets them out of that range. As we mentioned, 80% of the open shunt increased in a clinically significant way. And the mean open shunt gait velocity change is twice the MCID, the minimal clinically important difference for normal elderly patients. And it's also higher than is the standard for the treatment of Parkinson's disease. So the combination of the improving gait, the decreased falls, means that we can have, just from the ambulatory effects alone, improvements in the health of these patients. So how many, as a surgeon, when you do this, how many would you expect to have to do before you see an improvement? That's the number needed to treat. And it turns out it's less than 2. So if you do just a few operations, you should be seeing improvements in your patients. It's a pretty low number for an NNT. And so we're encouraging the evaluation and the treatment of NPH. The results that are pending, I've said a number of times, we have a lot in the future. We have the long-term studies to look at the durability and the evolution of the effects. We are looking at the CSF biomarkers, not only in the 100 patients, but in 200 to 300 other patients that are controls to see about biomarker differences in these groups. We're also looking at, there's about 160 measurements of morphological changes that we're looking for in the imaging. And we're also doing DTI, functional MRI, and connectivity studies. All those we hope to publish within the next year and based on the 12-month outcome studies. The hope is that we can integrate the functional improvements with anatomical changes in the patients and with neuropsychological changes to get an idea of what areas might be changed with treatment of NPH and how that may be affecting a person's function. So that in a nutshell is where we are right now. We hope over the next years to be coming out with several other papers just based on the large amount of data that we have. And we hope that these results, though, are going to encourage the referral and evaluation of patients for INPH. And to end and get back to our track of collaboration, this has been a study which is, as I said, a team of teams. There's been many players involved, and I'd stress the group, the BIOS group here, that was instrumental in helping us organize the study and execute the study, as well as the Utah group for the data analysis. But it was a collaboration of many groups, and I think you're going to hear more about how that proceeded momentarily. Yeah. So Dan has a group of excellent people that we're in contact with almost on a daily basis, certainly on a weekly basis. Nicole has been instrumental as overseeing the entire PENS project and how it proceeds. And I've been, in getting in this, realized just how much was involved and how many meetings and how many groups. And at some time, I think we all thought, is all this necessary? Can we get a red cap? And the point is, it is necessary to put out a quality study. All the things that Nicole oversaw in terms of quality management, talking to the sites, enrolling, all those efforts. While they took a lot, the group did that, led by Nicole. So I'd like to invite her up to speak a little bit about the PENS project in context of their group.
Thank you, Mark, for that introduction. And we are excited to share in the success of the PENS Consortium. I think we're okay. Thank you. So I'm Nicole McBee. I'm the Executive Director of the BIOS Clinical Trials Coordinating Center. And as Dan said, we are in our 25th year. We're celebrating our 25th year as an academic research organization here at Hopkins. And our focus is in team science, clinical trials science. So as each of you are looking at all of the biology and all of the wonderful things that can be done to help patients in the world, we're that infrastructure behind it to help produce quality results that investigators can have confidence in. And it is that p-value accurate, essentially. So along the way, proactively, we're doing all of the things to bring quality, regulatory compliance, participant safety, and all of those things. So we are a group of about 60 staff members now, faculty and staff, and our faculty under the direction of Dan Hanley, are clinical trialists. So essentially our tagline is, you bring the science, we'll bring the clinical trial know-how, and together we'll do great things. So excited to share a little more about that. Building on what has been shared so far, and using a similar timeline to what Mark showed, essentially as the idea was forming back in prior to 2017, the Trial Innovation Network was also born in 2015. And the Trial Innovation Network is a consortium pulling together the 60 plus clinical and translational science awards, CTSAs, across the US. Hopkins is also a CTSA. They go by the acronym ICTR. It's alphabet soup all day long. So the Trial Innovation Network in 2015 was young, and the mission of the Trial Innovation Network is to find ways to accelerate clinical trials, get those trials done faster, more efficiently, so that translating the science, the question, answering the question, getting a new practice, a new validated treatment to the bedside faster, as fast as we can, to help the community. At the end of the day, the patients are where we're targeting. So in 2015, 2017, Mark applied to the TIN for consultation, and BIOS is funded. We're in our 10th year of funding, has a Trial Innovation Center within the Trial Innovation Network. So partnering with Mark and his consortium in 2017 to do consultation of helping him design the study design of the PENS pilot. So that first study, using 3 sites, the fledgling newly formed AHCRN, to answer the question, is it safe, is it feasible to do what the PENS trial ultimately showed? So we brought to the table those accelerated efficiencies and the infrastructure, as he was navigating the roadblocks behind this. The no study infrastructure roadblock is what we helped him to speak to. And we brought to the table site qualification methods, and that is to support enhanced site performance so that your trial performs, your enrolling site performance, accelerated site startup, having a sub-award site, so Hopkins managing another academic institution to start up to be able to enroll patients. That involves IRB approval. You have to contract with the site, regulatory training, regulatory documents, all of those things we've organized into a 90-day protocol. So in 12 weeks, we are navigating sites through all of those steps to start up, and that is addressing an inefficiency that for very long, it could take years to start up a site. So we tested qualification, accelerated site startup, and at the time, the common rule had just changed in 2017-ish to where Hopkins was now organizing as a central IRB, because NIH said every federal funded study had to use a central IRB. So SIRB coordination was in its infancy as well in the Trial Innovation Network to help navigate the space between the SIRB here at Hopkins and those enrolling sites and their local IRBs, which are still involved. So moving through the timeline, funding success, the PENS pilot occurred and resulted in the findings that it was feasible and safe. So they moved forward with the U01, as Mark talked about, and we continued our collaboration with Mark and the AHCRN and the University of Utah Data Coordinating Center, and with BIOS as the clinical coordinating center. And now we added to the same innovations. We're now testing the evolved and process improved, because every trial, and PENS wasn't the only one, multiple trials within the Trial Innovation Network are benefiting and testing our innovations of clinical trial methods. So retesting a trial within a trial, if you will, these clinical trial methods to improve clinical trials overall. And we added the bottom one there, CTSA site networks. Now we have an established process within the TIN to reach into those 60 plus CTSAs, as Mark described, to help you find qualified sites, investigators at those sites, and they're large academic institutions just like here. So you can imagine Disease agnostic is the TIN. Any population, any intervention, we're able to dig into those 60 plus CTSAs and find the right department, the right investigator who's interested in participating, collaborating, and enrolling in the trial. It's not the end. The PENS trial, as Mark said, we're at the halfway point with preliminary results, preliminary promising results, and now we're looking at the next one. So Mark has applied again for consultation to look at study design of the spin-off trial, and I fear I've made, no, Infinite, it's now spelled correctly, to assess the diagnostic criteria for shunt placement determination. So always looking for that next question to help really hone in and make sure that the intervention we're finding is comprehensive. So along the way, building out those consortiums through these consultations, at that idea formation stage, as Mark said, it was a pretty small group. So Hopkins, Cleveland, UMEA, were thinking and percolating the idea for years of what it would look like. And with the NIH, NINDS saying, no, you need more infrastructure. Well, for the PENS pilot and through connections and collaborations and through the Trial Innovation Network first consultation, his consortium expanded to include BIOS as the Hopkins TIC, Trial Innovation Center, as the clinical coordinating center with the study team. We don't take over the trial. We're here to complement and support and bring all of those things Mark talked about. And it also added the sites from the HCRN and the STATS, Data Coordinating Center from Utah, the 3 to 5 enrolling sites, and then Calgary was added with Mark Hamilton as well as part of the HCRN. That PENS trial consultation that led to the funded U01 added even more complexity to the trial, larger multi-center network, which brings the need for more infrastructure to manage the complexity. So now we've added the VUMC RIC in the top right bubble there. And that is part of the Trial Innovation Network to support specifically around recruitment and retention above and beyond what the Coordinating Center was doing. Many cores were established to look at the various secondary endpoints and co-primary endpoints for the statistical analysis plan, including the CSF core, the imaging core here at Hopkins, the neuropsych core, and the GATE core to look at the primary outcome, and then many subcommittees. So it is a meeting upon meeting, but it's a information flow management across so many moving parts to make sure that this entire village is functional. We also bring to it we being BIOS, and I won't spend a lot of time here, but it gives you a sense of all of the things that have to be done and all of the standard operating procedures that we've refined over 25 years to make it pretty streamlined and transparent or not to the study PI of you focus on the science, we'll report up to you as we're managing performance of your trial, your clinical sites, and to make sure you have confidence in your data and you're completing on time and on budget, which is how NIH determines success. So we are open and we're willing to talk to anybody. BIOS is funded, like I said, as a trial innovation center to do consultation. So for your next multi-center project that you're thinking about, come talk to us. We'll help you design, and it's an initial consultation, pretty small commitment, 30 to 60 days. We'll spend time with you depending on your schedules, usually more like 30 days, but it could be 60 to help refine that idea to take it to that next step. And if you do decide that you want to move into a collaboration with BIOS, then we will enter into a comprehensive consultation and we'll prepare that grant with you. We become part of your grant application to bring all of that infrastructure. Bottom line, it's easy to apply, trialinnovationnetwork.org. Website is on the bottom there. Lots of information up there of what is available to all investigators above and beyond consultation. There's a wonderful toolbox up there. And then what makes a good proposal, you can read up there as well. And with that, I'll turn it back to Dan for any questions. Thank you.
So we're running a little over. We need to get to the OR for everything. Okay. Yeah. So I'd like to open it up to questions for Nicole, Mark, me. And we have two other members, Lindsay and Karen Lane, coming in by video. Is anybody thinking about a trial? I know several of you are, that need some more fine tuning. Yeah.
Dr. Finley, for residents, faculty, students who are interested in starting an interventional clinical study.
Yep.
You guys have been amazingly helpful through the trial advisory program. I haven't come across the TIM before. Functionally, what's sort of the difference?
Sure. The trial advisory program is run out of the ICTR, and it's a short version of what you heard today. It's a 1-hour consult with 4 or 5 of the best trial people in the institution. Dan Ford, Charlie Flexner, Doug Jabs from the School of Public Health, and myself and Nicole. And we bring in other people, and you just talk for an hour. If like the Trial Innovation Network is free. The Trial Innovation Network, if you have a multi-center trial and you want a consult for all of the coordinated activities, you go to the ICTR, to Dan Ford, and you say, I'd like one. And they write a letter. And in 5 days, we start a process of doing a much more complicated consult. The initial one there takes about 30 days and involves 1 or 2 or 3 meetings. It depends upon your schedule. So if you can't do it in 30 days, it can get prolonged. And then if you have a group that really is moving forward, we will ask our partners who are at Vanderbilt, and we have a discussion and say, can we move on and work with you over the next 9 months to put in a proposal? And we haven't said no to anybody. A lot of people decide they're not quite ready to do all the things that Mark eventually did, and you can see it takes time.
Thank you.
Mark.
Just make a quick comment about the innovation. Like just that one process of finding who around the country would be a good site for the study. That was go to the whole SASE and interview form and fill it out back and forth. And that's something we found new sites. I didn't know when I was doing that was really just in a sense of new innovation that's been trying to do efficiency. I thought it's just something I didn't know about, but it was an excellent process. There was one that I will mention, that was the incentive one, where we would give the institution badges, like Superman badge, flying high badge, so forth. And I have to admit, I cringed a little bit when Dan Farrell got a little badge. That he had admitted a patient and so forth. So obviously these things are all in development, and we're trying to figure out what's the most appropriate thing. But that's kind of the fun thing itself. We're trying to get ways to enlist the sites, get them motivated. So I think it's all in the right direction.
So to reach into 60 CTSAs and into their electronic health records to find, do they actually have the patients, and then to hold a series of presentations with the research staff at those 60 requires a lot of organization. That's what one of the things we did for Mark. The other thing that is underestimated is to then get those, in Mark's case, I think 15 sites up and running. You get 5 years worth of money from NINDS, and if it takes 2 years to get them up and running, that's 1.5 years or 1 3/4 that you're not finding patients. And that's the single most important thing in getting performance out of a consortium. You want to speak to?
I would like to add. So thanks, Mark, for bringing up gamification, which I didn't highlight in our presentation, but that is a wonderful example of how to manage site performance, motivate the sites, reward the sites without cost. And it's very data driven. So everything we're doing, we have so much data, metadata, workflow data on all of these things so that we can process, improve, and measure pre and post, just like you're doing in the biological science. And the gamification process is built on about 10 different metrics that result in you get a badge, so that sites can then have that sense of competition and individual within institution self-worth, just to give them that extra sense of motivation above and beyond. We met our recruitment, our targets. So data driven is the point I wanted to make. Thank you.
Yeah, great. I think that's important. The other word that Nicole used was metadata. Mark talked about the biologic data in his trial, but now with electronic data capture platforms, we have all other measures of performance as well. And we look at that to look for roadblocks that we can overcome. And we make that process of data gathering transparent to everybody on the team. So that big set of networks in Nicole's network slide, everybody can look at things and improve the data quality. Like the core labs, the core gate lab in Mark's trial, improving how gate speed was measured and applying a central scored mechanism for making that measurement, which increases the reliability and precision of the measurement. Okay, I guess we need to go to work.
Hi, I'm good. How are you? Good to see you. Oh, yeah.